Similar to Class 2 Division 1, the molar relation Class 2 Division 2 is Class 2. However, the incisor relation is different in that the upper incisor is retroclined and the overjet sometimes is normal or minimum. Class 2 Division 2 could appear when their skeletal pattern is mild Class 2 or sometimes even Class 1. The main effect would be the lower lip action. The vertical dimension is basically, and due to the vertical dimension, the mandible will be forwardly positioned and result in prognathic mandible. And the etiology of the soft tissue in Class 2 Division 2 is mainly attributed to the effect of lower lip. And this is because of the underlying skeletal pattern. When there is a reduction in the lower facial height, the positions of the lower lip would be higher, and this high lip line will exert pressure to the upper incisor, especially during eruption, and so it causes retroclination of the upper incisor, like in these cases. For the lower incisor, the story will be different because of the crown length is shorter in the upper lateral incisor, so the effect of retroclination will be very minimal, or sometimes even the upper incisor will be in the normal inclination or with some sort of rotation, mesorotation, and that's occur in typical Class 2 Division 2 cases. However, when the muscle action and the size, the length of the lateral incisor is acknowledged, so the effect of the lower lip would be on the upper as well as the lower incisor, result in what we call the bimaxillary retroclination. Regarding dental causes, well, crowding is a common feature that could be seen in Class 2 Division 2 cases, especially in the upper arch. And this is because of that teeth occupy a smaller arc, and similarly, because of the effect of the lower lip on the lower incisors, this will cause crowding in the lower jaw. This crowding is important in treatment, and we will discuss that later. However, because of lack of occlusal contact between the incisors, the lower teeth would be erupted and cannot be stopped, and this will cause deep bite. The odontogenic features of Class 2 Division 2 are characterized by having the upper central incisor retroclined, whereas the upper lateral incisor sometimes may be average or proclined, depending on the size of the incisor, or even retroclined if it is well proportioned. In severe cases, we may have a bimaxillary retroclination. In these cases, we may have the lower incisor have a traumatic bite with the palate, or the upper incisors have a traumatic bite with the labial gingiva. Another feature could be seen in Class 2 Division 2 is the lingual crossbite or the scissor bite, and that could be on the upper first or second premolar. Management of Class 2 Division 2 should be directed toward reductions of the increased overbite and reductions of the interincisal angle. The interincisal angle can be dealt with using different bracket with different torque mechanics. Treatment consideration in Class 2 Division 2. Well, the treatment options depend on different factors such as the etiology of malocclusion, the presence of crowding, patient profile, the age, and a lot of factors. However, these are the most important ones. It's very important to understand that most of the cases of Class 2 Division 2 treated with non-extraction approach. However, in certain and very small cases, extraction can be planned. So, how to reduce the overbite? We have different treatment line. The first is the intrusion of the incisor, and this depends on different factors, such as the lip line, the incisal show, as well as the vertical dimension. There are different ways, like for example, using the TADs for intrusion, or sometimes we have the intrusion wires. Or sometimes we can do a relative intrusion of the incisors by slight extrusion of the upper posterior teeth. However, the true intrusion can be done simply by using the temporary anchorage devices with elastics, or by using step-in wire and different other mechanics. Okay, the second line would be eruption of the molar, and from this terminology we can understand that we need to capture the patient in the growing stage. And here, simply by using upper removal appliance with flat anterior bite plane, this will free the occlusion posteriorly and let the teeth erupt. And so when the patient captures in proper age, this eruption is physiological, and at the end of the treatment we can see, because of the contact of posterior teeth, there will be some intrusion in the anterior teeth. The third line would be extrusion of the molar, and here, when the patient past the growth period, we can use the fixed appliance with different elastics, like in these cases. And this is important in cases of reduced vertical proportions, as this will cause eruption of the posterior teeth and so increase in the lower facial height. We may also do proclination of the lower incisor, and this is one of the common mechanics used in Class 2 Division 2 cases. And here can be done by using fixed appliance to procline the lower incisor, or sometimes we can use upper removal appliance with inclined anterior bite plane. This will cause sliding of the mandible, as well as causing pressure and proclinations of the lower anterior teeth. The final approach would be surgery, and this is indicated when the patient is adult and the deep bite is so severe, and this can be done by using anterior segmental osteotomy, whether in the lower jaw or in the upper jaw. As with Class 2 Division 1, the first line of treatment would be functional appliance, which can start with pre-functional face using removal appliance with inclined anterior bite plate, or sometimes we can use true functional appliances like functional regulator and so on. And these appliances would direct the treatment with proclinations of upper and lower incisors and adjust the skeletal relationship. Sometimes we may incorporate the fixed and removal appliance. Well, fixed appliance in order to procline the incisor and change the case into Class 2 Division 1, and the removable appliance is the myofunctional appliance, whether bionator or functional regulator. This will have the advantage of reduce the time of treatment. The fixed appliance treatment can be directed toward interincisal angle and dealing with crowding. The interincisal angle should be reduced, and this can be done by proclinations of the lower incisor and applying of torque in the upper incisors. The proclination of lower incisor will eliminate the crowding in the lower arch. At the end of the treatment, we should have a good cuspal interlock to enhance the retention. The final line of treatment is orthognathic surgery, and this should be directed toward improvement of the facial appearance as well as the occlusion. but it needs pre-surgical orthodontics in order to coordinate the occlusion and proclinations of the lower and upper teeth. However, the relapse rate is high. Definitely, orthodontic surgery is indicated when the orthodontics cannot do an improvement for the case, like in severe cases, or an adult where improvement of the facial proportion is indicated. Thank you for your attention, and all the best for the exam.